my talk will be basically on the pharmacology to some extent and the use of pharmacology in medicine, because I think we are all practitioners who like pharmacology which is useful and not the stuff which can't be used. So when we are starting anticoagulation in patients, it means we are between the devil, which is clotting, and the deep sea. This term between the devil and the deep blue sea or the deep sea has come from the sailors. They used to be hanging on the ship's deck, and if they fell, they were on the deck, which would fracture them, and if they fell on the other side, it was the sea. So that's how this term came. So I think it's a very apt term for starting anticoagulation. You have that fear all the time. Is this guy going to clot or is he going to bleed? So the key players from the clinical point of view, I will just touch them. Fibrin is one of the key players in the clotting story, and in the bleeding story as well. So the fibrin, being the center player, is the captain of the team. The activation and the production of fibrin is going to go up by activation of platelets and by activation of the coagulation factors. And the production of fibrin is going to go down by inhibition of the activated coagulation factors, and of course by fibrinolysis. So this is the key sort of player in the mechanism of coagulation. The other thing I just wanted to touch upon was the coagulation cascade in a nutshell. So if you have a wound, essentially factor 7 is activated, so it becomes factor 7A, and with a tissue factor, it activates factor 10 to factor 10A, and of course through factor 9 as well. There's an alternate pathway through factor 9, which becomes factor 9A, and again there's an activation of factor 10 to 10A, and then 10A of course converts prothrombin to thrombin, and thrombin of course is again a key player and produces fibrin, and then fibrin produces the clot. So this is one of the very important thing that you need to know, that there are two key players in terms of anticoagulation, the 10A and the thrombin, and of course in terms of fibrinolysis, the fibrin. The thrombin has an amplification activity through factor 9A, that is factor 9 to factor 9A conversion, and again to 10A. So if you look at factor 10A, then the substances or the molecules we have which act on the factor 10A level is heparin, low molecular weight heparin, fondaparinux, and 10A inhibitors. So those are acting at the 10A level. And if you look at the thrombin level, then of course the heparins again act at the thrombin level, at the low molecular weight heparins also act there. And then you have the direct thrombin inhibitors. Direct thrombin inhibitors are oral and IV. So the other two key players which I want to use, so one key player of course was the fibrin and the thrombin and the fibrin, but if you look at factor 10A and thrombin, they are present in two forms. They are present in the circulating and the clot bound forms. So thrombin, factor 10A, which are really the two key players for anticoagulation, have two forms, clot bound and circulating. And the direct thrombin inhibitors and the factor 10A inhibitors act on both forms, the clot bound and the circulating, while heparins act only on the circulating forms. Of course, we'll talk about the available anticoagulants in India, because I think that's what we want to focus on, is the practical part of the issue. You have unfractionated heparin for a very long time. You have low molecular weight heparin. You have fondaparinux now for some time. The direct thrombin inhibitors, that is Dabigatran, and direct factor 10A inhibitors, rivaroxaban and apixaban. So you're essentially looking at this sort of combination treatment which you can think about or use singularly. The directly acting oral anticoagulants over the old horses, which is heparin and warfarin, the advantage of the DOACs is that there is a lower bleeding risk, and this is clearly shown in less fatal intracerebral hemorrhages. So the neurologists are very happy with the DOACs, less intracerebral hemorrhages. No lab monitoring, less variation in relation to diet, medications, acute illness, and rapid onset and offset of action. I think that's the advantage. It can be a disadvantage as well, but I think mainly it's an advantage, rapid onset and offset of action. The disadvantage is of course the cost, which I'm happy to say that it's, at least for Dabigatran, we are looking at coming off patents is a good thing for a third world country like us, which can't afford the cost. So cost, hopefully will go down as it is. Dabigatran has come off patents. Lack of monitoring, of course, is an issue sometimes with DOACs. I have not found it to be a big issue practically. Antidote, of course, Dabigatran has adagrasuzumab, and which is a tongue twister in itself. So I prefer Praxbind, as a, maybe that's the reason why they've kept it such a tongue twister. So specific clinical settings, which anticoagulant to use, when you have a non-valvular atrial fibrillation and you have a CHA2DS2-VASc greater than 2, and you can start a DOAC or a warfarin. If you have a prosthetic heart valve, classically it's warfarin. But I think, Amit maybe will touch on this, that some of the trials, specifically RELY and so on, had patients who basically had valvular disease which was not severe, or had disease which was bioprosthetic valves, not metallic valves, and so on. So, but I think on the whole, warfarin is like 80% or 90% in that game. Pregnancy, of course, because of safety issues, if you need an anticoagulation, it's a low molecular weight heparin. It's a safety which takes over everything else in pregnancy. In moderate renal failure, with the creatinine clearance is 30 to 50 ml, it's apixaban. So apixaban scores a little bit over the other DOACs or NOACs in this situation. If you have a severe renal failure with creatinine clearance less than 30, warfarin is the drug of choice. So here is the choice that you can make. If you have an APLA syndrome, heparin followed by warfarin. Again, this is because of lack of evidence in terms of DOACs and NOACs. I think it's just that these are rare disorders which still need to be studied. If you have compliance problems, then maybe warfarin is preferred. This is can be monitored, has a long half-life. So if you miss out a tablet or two of warfarin, it doesn't too much matter. But if you miss out a tablet of a DOAC or a NOAC, the blood level can drop very fast. So, and it may be especially true for the BID or twice daily DOACs, which is Dabigatran or apixaban. So I think this is true. Dropping out tablets can be a major problem. Gastroenteric disease like ulcerative colitis, Crohn's, and Dabigatran has a little bit higher risk of bleeds from the intestine, from the GI tract. So Dabigatran is a little bit of a problem there. Cost problems of DOACs, as I said, will become less with Dabigatran coming off patents. I am told that Dabigatran therapy now, if coming off patents from the Indian scenario, is going to be 50 rupees a day, and it used to be 150 a day. So I think it's substantial difference that it's off patents. Of course, this is, hindsight is an exact science. So sometimes, we worry about our patients, without having too much foresight. The bird's eye view, I think already, since Jayanto has already spoken about it on this. The only point I wanted to make in this slide is that you have Dabigatran, apixaban, rivaroxaban. You look at them, they are similar, except that you have to use a BID dose for Dabigatran, apixaban, whereas you use a OD dose for rivaroxaban. And the other important thing which I think Jayanto pointed out is Dabigatran is 80% renal cleared, whereas apixaban, rivaroxaban may be a little better in that scenario. Antidote, of course, is available for Dabigatran. All DOACs have the following indications, which is non-valvular atrial fibrillation with CHA2DS2-VASc greater than 2, which is all non-valvular AF who come to a neurologist, probably to you as well. Venous thromboembolism is the other indication, and acute coronary syndromes, I think there is a question mark on that for chronic anticoagulation, which I think is again where Amit will probably be able to enlighten us. Your baseline test before starting DOACs is a platelet count, a PT-PTT. The platelet count PT-PTT is just to tell you that your coagulation system is okay before you start him on a NOAC or a DOAC or an anticoagulant. And creatinine LFT to tell you that the liver or the kidney is working fine. So you don't have to worry about the liver or the kidney in terms of bleeding propensity. And one of the other important thing is the history of bleeding. Dabigatran, this is a little busy slide, but I'll try to, sort of, bring it into a nutshell, is that Dabigatran, the standard dose of Dabigatran is 150 milligram twice daily. And then if you have a you have special scenarios, of course, of venous thromboembolism and either primary prophylaxis or venous thromboembolism treatment or secondary prophylaxis, then you use a little different dose. But by and large, I have used the 150 milligram BID as a standard dose. You go to 110 twice daily if age in stroke prevention and atrial fibrillation. I'm talking about stroke prevention and atrial fibrillation. 150 twice daily is a standard dose. 110 milligram twice daily if age is greater than 75 or creatinine clearance is less than 30 ml per minute. The venous thromboembolism, you have a primary prophylaxis in surgical patients. Now, it's very important for me to emphasize that DOACs or NOACs have not been tested in medical patients for prophylaxis of venous thromboembolism. Because, here I think we are more medicine people rather than surgeons. And so we need to understand that they have not been properly evaluated. So the primary prophylaxis of venous thromboembolism, that is the DVT prophylaxis, the primary prophylaxis for DOACs is basically in surgical patients. So 110 milligram 4 hours after surgery, little complex dose, but followed by 220 milligram once daily for 10 days. This is for knee replacement. And 220 milligram once daily for 30 days, which is hip replacement. And this is for surgical patients, prevention of DVT. And if you get a venous thromboembolic phenomena, treatment and secondary prophylaxis, the dose is different. It's 150 milligram twice daily, which is the standard dose other than what you'll use for primary prophylaxis. So it's a different dose for primary prophylaxis, it's a different dose for treatment and secondary prophylaxis. If the patient's weight is greater than 120, you should avoid Dabigatran. I think its pharmacodynamics becomes difficult to really predict. And you cannot, the other issue I found a problem, it's a practical problem with Dabigatran is a lot of our stroke patients are on Ryle's tubes. And we do have a problem with Dabigatran in that sense because it cannot be opened and put into the Ryle's tube. And because its activity, its absorption becomes erratic and its activity changes. So that's one of the practical issues with Dabigatran. Hopefully it should be solved over time. Of course, there's an antidote available which is non-pronounceable, but it's available, and it's Praxbind. Rivaroxaban, again, for stroke prevention in atrial fibrillation, that's the first indication, 20 milligrams once daily. And this 20 milligram once daily is the sort of the ballpark dose, as 150 milligram twice daily is the ballpark dose for Dabigatran. 20 milligram once daily is the ballpark dose in terms of stroke prevention atrial fibrillation. 15 milligram in patients with creatinine clearance less than 50 ml per minute. So you have a renal dysfunction, you worry about the dose. Venous thromboembolism, primary prophylaxis in surgical patients. Again, it's surgical. I've underlined the surgical. 10 milligram once daily for 10 days for knee replacement and 10 milligram once daily for 30 days in hip replacement. And venous thromboembolism treatment and secondary prophylaxis is 15 milligram twice daily into 3 weeks and 20 milligram once daily. So the venous thromboembolism part is a little tricky and you need to see it. Apixaban is, of course, is another molecule which is now come up pretty well. It's the stroke prevention in atrial fibrillation. You would use a 5 milligram twice daily dose and change it based on if the weight is low or the creatinine is high. In venous thromboembolism, primary prophylaxis, again in surgical patients, you would use a 2.5 milligram twice daily, 10 days knee replacement, 2.5 milligram twice daily, 30 days hip replacement. And venous thromboembolism treatment and secondary prophylaxis, you use a 10 milligram twice daily for 7 days. Apixaban is one of the renal-friendly DOACs which you could use. I'm not going to go to shifting in the dose, but I'm going to just quickly end with this venous thromboembolism prophylaxis after stroke. Peak incidence of DVT is 2 to 7 days post-stroke, and you must make a note of that. The risk of death in an untreated DVT in stroke is about 15%. It's essential to prevent DVT after a stroke. And thigh-length intermittent pneumatic compression devices within 72 hours for patients with reduced mobility. I just wanted to make a comment here that sometimes you get patients who are transferred from other hospitals to you third, fourth, fifth day of stroke. Be careful of starting the pneumatic compression devices because you may actually dislodge a clot which is already formed there. So if you have a patient who comes in 3 days after a stroke and you want to start him on a pneumatic compression device, you need to check and look that there's already no DVT in the leg and then only start the pneumatic compression. The VTE prophylaxis after stroke is enoxaparin 40 milligram once daily, or if your patient is not very affording, unfractionated heparin 5,000 units 8 hourly. Prophylaxis is for 2 to 4 weeks, not for very extensive time. And the new kid on the block is the only proven DOAC in venous thromboembolism prophylaxis for medical patients is Betrixaban. And Betrixaban is not yet available in India. But this is probably going to be the new kid on the block. So I thank you.